about important topic which is tuberculosis, its epidemiology, its pathophysiology, various diagnostic modalities, treatment and various organizations which are in the collaboration with the National Tuberculosis Elimination Program. Starting with an important point of tuberculosis is that one case of untreated TB can lead to 10 to 15 new cases per year. World TB Day is observed on 25th March. The TB program has been revised per year according to the year. In 1962, it has been a National Tuberculosis Control Program. In 1997, the major changeover, this has been changed to revised National Tuberculosis Control Program. The importance of this is DOTS regimen, directly observed treatment short course. In 2020, it has been renamed as National Tuberculosis Elimination Program. The theme of this program is called as the TB Harega Desh Jeetega. So epidemiological determinants. So mainly it includes a triangle of agent, host and then the environmental factors. So agent which is caused by the Mycobacterium tuberculosis, which is an acid-fast bacilli because it resists the decolorization because of the presence of mycolic acid in its cell wall, and it is an obligate arrow which requires an oxygen and facultative intracellular organisms. Other atypical mycobacterium includes photochromogen, pseudochromogen and non-photochromogen. And what are the host factor? The mainly age. So the people who are prone for tuberculosis, which includes the age between 15 to 45 years of age, mostly they are a case of undernourished or malnourishment has been a major risk factor. In social factor, which includes the people living below the poverty line, that is undernutrition, malnutrition. Next, pathophysiology, which is an important part, how the TB has been spread from one person to another. It is an airborne droplet infections. So primary TB. So when TB first infect the person, it mainly infect in the hilar region of the lungs. So which is called as the Gaunt complex, Gaunt foci. Along with the involvement of one lymph node is called as the Gaunt complex. When this complex is calcified, it is called as the Ranke's complex. Usually most of the peoples are primary, 40% in India are primary TB, but 95% of them are healed, so called healed TB. And only 1 to 2% of the persons are converting into progressive primary TB, and 2 to 4% that is the bacilli remains dormant in the lung, which is called as the latent tuberculosis. Later this latent tuberculosis undergoes reactivation because of any stresses. So it forms a cavitation mainly in the upper part of lung. Why the upper part of lung, which is most commonly infected? Because it where more ventilation is there and decreased perfusion, V by Q ratio is higher because of delayed hypersensitivity reactions. Next, diagnosis. So just starting, it has been initially if a patient comes with any symptoms of fever, cough or night sweat, we first investigate the patient with chest X-ray. Usually it is a non-specific and non-sensitive test. Later, the new sputum testing was done, which is a good high sensitivity and good specificity has been found. So the method, that is proper sputum should be about 5 to 10 ml, and then it should be an expectorated sputum, which should have a mucoid, purulent or mucopurulent in consistency. The percentage of squamous epithelial cell, that is from the upper respiratory tract, it should be of less than 10%. Next, we have another renowned method of in the investigation was genotypic method, which has been revolutionized the diagnosis of TB over the time, which is CBNAT, that is cartridge-based nucleic acid amplification test. Because why I told it as revolutionized? Because the turnover time is around 2 hours. Next, TrueNAT, which is an Indianized version, which is first found in Goa, and the turnover time is around 1 hour, 60 minutes. Next, we have the line probe assay. Line probe assay has an advantage of detection of the resistance of the TB organism to the drugs which are taken, which includes isoniazid, rifampicin. And CBNAT has also an advantage of detecting the rifampicin resistance against the bacilli. So as already mentioned, the genotypic method, which includes CBNAT, TrueNAT and line probe assay. CBNAT has an advantage of detecting the rifampicin resistance, and then the line probe assay it has detected the resistance to the isoniazid. So what are the genes responsible for the isoniazid resistance? INHAA, CATG. Next, fluoroquinone, GYRA, GYRB. And kanamycin, amikacin and capreomycin, it is by the gene RRS EIS promoters. Next, after sputum testing, so what are the parameters which must be considered? So to say it is a negative, there should be a 0 acid fast bacilli in 100 high power field. For scanty 1 to 9 best acid fast specified in 100 high power feed. Next 1 plus 10 to 99 acid fast specified in 100 high power feed. And 2 plus it is 1 to 10 acid fast specified in 1 high power feed. 3 plus is more than 10 acid fast specified high power feed. So after the genotypic method, the new methods are going to be phenotypic method, which is going to be the culture media, so solid culture media and then the liquid culture media, which is with the help of a method called backpack method and MGIT methods. So solid media is going to be the Lowenstein-Jensen media, which is the LJ media, so which detects the acid fast specified in the period of 8 to 10 weeks. Next we have the liquid, which is by the Kirchner's methods or the Middlebrook method, which detects the acid fast specified within the interval period of 1 to 2 weeks. Other methods which include serological method, which IGRA method, that is immune gamma release assay, which is not following Indian as standard. Next we have the antigen antibody test, that is quantification test, which is also of not in use of these days. Next you have the tuberculosis skin test. Here 1 unit of purified protein derivative is injected in the forearm intradermally, and for it should the reaction presented are going to be weak and flare, which is going to be observed after minimum time interval required is 48 hours, but within 96 hours it should be noted. If it is more than 5 mm, it is taken as positive in case of people with HIV or any immunocompromised state and people who are in contact with the MDR patients. Next, more than 10 who are immigrant from a TB endemic areas. Next, more than 15 in case of normal people. So what are the targets of this NTEP program, which is NTB, so which means reduce the TB death rate, and then you have to reduce the TB instance. So WHO has one protocol and SGD has one protocol and NTEP, which is for India, has another protocol. According to WHO, you have to reduce the TB death rate by 2035 to 95% and TB incidence by 90%. Whereas SGD, the Sustainable Developmental Goals, it has to reduce the TB death rate by 90% and TB incidence by 80% by 2030. And India, we have to reduce the TB death rate less than 90% and incidence by less than 80%. So, diagnosis of the TB. So, before diagnosis, we have to do some basic definition, which is the presumptive TB, and then we have the presumptive MDR TB. So, what is presumptive TB? Which includes the person who is having fever, cough for more than 2 weeks, along with that with or without night sweats and significant weight loss, is called as presumptive TB. If a person is called a presumptive TB, then we have to do following methods of diagnostic modality should be followed. The sputum along with the nucleic acid amplification test, chest X-ray. So if any sputum and NAT, which is of high sensitivity and specificity, comes out to be positive, we are calling them as the patient with tuberculosis, and negative, it should be sent to another medical officer for further investigation and evaluation. Following positive of these by this method, already by NAT we will able to suspect whether the patient is resistant to rifampicin or they are sensitive to rifampicin. If they are sensitive to rifampicin, we have to follow drug sensitive TB regime. In case if a person is resistant to rifampicin, next we have to undergo another method of investigation, which is the first line probe assay and second line probe assay, which helps in detecting the resistance to other group of drugs like fluoroquinolones. Identification is by these methods, which may be H monodrug resistant, multi-drug resistant TB, polydrug resistant TB, extensive drug resistant, and then pre-XDR TB is called. Presumptive MDR TB, which includes following categories of patient. So first is the patient who has been on ATT, that's anti-tubercular treatment for 1 month, and then they are not, there is loss to follow. And second group of patients who are taking anti-tubercular treatment, but they are positive sputum culture in 3rd and 5th month. And the patient requires recurrent TB, and the fourth group of patient is that who are in contact of MDR patient, they are called as presumptive MDR TB. So following investigations like NAT and first line probe assay has to be taken. So it shows following group of modalities, so which may be sensitive to rifampicin and sensitive to isoniazid. So following drug sensitive TB regimen. Next, sensitive to rifampicin, resistant to isoniazid. Next, you have resistant to rifampicin and sensitive to isoniazid and resistant to both group of drugs. So we have to undergo further investigations like first line and second line probe assay has to be taken. So if a patient is resistant to rifampicin and sensitive to isoniazid and resistant to both these group of drugs, which may be due to mutation either one gene mutation, that is INHA promoter or CAT gene, or two gene mutation. If the patient has only one gene mutation, it is by the taking shorter oral bedaquiline regimen, and if the two gene mutation, longer oral bedaquiline regimen has to be taken. So what are the drugs which is included in the TB regimen? So as we all know, isoniazid, rifampicin, pyrazinamide, ethambutol, and other group of drugs like group A drugs, group B and group C. So group A drugs which includes levofloxacin or moxifloxacin, and then you have the bedaquiline and then linezolid. Group B drugs which is clofazimine and cyclosidine group of drugs. Group C drugs, pyrazinamide, ethambutol, cyclosidine, imipenem and amikacin group of drugs are included. So what are the drug regimen which is followed? So drug sensitive, if a patient is diagnosed with a case of drug sensitive TB, then we have to undergo the treatment for 6 months. So 2 months of HRZP, that is isoniazid, rifampicin, pyrazinamide, ethambutol, and 4 months of HRE, isoniazid, rifampicin and ethambutol. So a patient is called as H mono or polydrug resistant. What do you mean by H monodrug resistant? The patient is resistant to the isoniazid group of drugs, and polydrug resistant is the patient who are resistant to any group of drugs not including isoniazid and rifampicin. So undergoing treatment for 6 months of pyrazinamide, ethambutol, rifampicin and levofloxacin. Next you have the shorter oral bedaquiline regimen. It is mainly for the patient who are MDR TB, that is multi-drug resistant TB. 4 to 6 months of clofazimine, isoniazid, levofloxacin, bedaquiline group of drugs. Next you have the ethambutol, ethionamide, and 5 months of same drug which has to be followed, and longer oral bedaquiline drug which includes 18 to 20 months of treatment, which includes levofloxacin, linezolid, cyclosporin, clofazimine and then bedaquiline group of drugs. So these drugs are taken according to the weight of the patient. So weight which is by the FDC regimen, fixed drug combination. So H, that is isoniazid 75 mg, and then rifampicin 150 mg, pyrazinamide 400 mg, ethambutol 275 mg. So if the patient weight falls between 25 to 34, and he have to take 2 tablets in intensive phase and 2 tablets in continuation phase daily. Next is 35 to 49, 3 tablets per day for 2 months of intensive and 4 months of continuation. 50 to 64 to 4 tablets per day. 65 to 75, 5 tablets per day, and more than 75 kg have to take 6 tablets per day for 6 months. So 2 months of intensive and 4 months of continuation phase. Moving on to the next topic, which is the case finding in tuberculosis, which includes 3 methods: passive case finding, intensified case finding, and then you have the active method of case finding. Passive case finding, which includes a patient comes with the symptoms of fever, cough for 2 weeks and with night sweats and weight loss, which means significant weight loss. Next we are testing for the tuberculosis test, which includes sputum culture sensitivity or the NAT testing. Next you have the intensified case finding, in which a patient is admitted in the hospital for any other illnesses, which is an immunocompromised state. Next following TB test is done. Next you have the active case finding, in which the healthcare workers they go into the field and identify the people who are with symptoms, and the following tests are to be done. Following are the incentives provided by the government, which includes the Dikshay Poshana Yojana, in which the diagnosed people with TB have been provided with rupees 500 per month. Next you have the tribal support scheme. In this scheme, every TB patient is being provided with rupees 750 per month. Next you have the treatment supporter honorarium, in which the tuberculosis patient with drug sensitive has been provided with rupees 1000, and drug resistant patient has been provided with rupees 1500. Next, incentives for the notification outcomes. So, if any healthcare workers inform to the government regarding the TB diseases, they will provide with rupees 500 for the outcomes as well as for diagnosis. Next, you have following are the IT schemes enabled in the service, which includes NICSHI. So, NIC means National Information Center, and SHI means which is TB in Hindi. So, in this scheme, following 99 dots therapy has been provided to the patient. In the fossil, when the tablet is being opened, the toll-free number will be there. The patient has to give missed call, so that the following will be enabled in the computer system of the NICSHI portal. Next is the MER container, which is the medicine event reminder monitoring services, in which a GPS enabled box is being placed. So following which the patient opens the box for taking the tablets, the portal will be enabled and the services and the notification will be sent to the portal. Next, what are the prophylaxis? If any patient who has been in contact with the TB patient, either the multi-drug resistant or drug sensitive, they will provide with following prophylaxis, which includes isoniazid 300 mg once daily for 6 months. If the patient is not affordable in taking for 6 months, next it should be shortened to 3 months weekly doses, which includes rifampicin and rifampicin and isoniazid. Next, what are the researches which are enabled in the tuberculosis program, which includes TB CHAM, in which the children in the age group of up to 10 years divided into 2 categories. First category of given are levofloxacin, and second group of people are given with placebo treatment. And next is Bequin research, in which all the age group from starting childhood, adolescent as well as adult, they have been divided into 2 groups and provided with levofloxacin, and another group is provided with placebo therapy. Next, you have the 4x theory. Next, what are the infection control methods? So, following collection of sputum sample, it must be disinfected with 5% of the phenol, and the sample has to be sealed with 3-layer protection container. If a patient is on OP basis, then the patient must be seated in this direction. So there must be a free flow of air. This method should not be followed. Next, we have the bidirectional screening, in which the patient who is diagnosed with TB has undergo other screening modalities, which includes for COVID-19, for HIV, for diabetes mellitus, and some severe acute respiratory tract infections. Next, so these are the organization which is in collaboration with the NTEP program, which includes the designated microscopic center. Next, you have the treatment provider. Here, total it includes the people range of 50,000. Next, we have the tuberculosis unit. Here, the people include a 1 lakh to 2 lakh population. Next, you have the district TB center. Next, you have the state TB center. Next, you have the central TB division. So, these are the categories of organization which are in collaboration with the NTEP. This has come to the end of the topic. So to revise, so the treatment modality forms the main important in tuberculosis. So which includes for drug sensitive TB regimen, you have to take a treatment for 6 months, which includes 2 months of intensive and 4 months of continuation phase. In 2 months, you have HRZT regime, which includes isoniazid, rifampicin, pyrazinamide and ethambutol. In continuation phase, 4 months of HRE, which includes isoniazid, rifampicin and then ethambutol. Next, you have followed a separate regimen for the H mono and polydrug resistance, as well as for the multi-drug resistant TB, as already mentioned. For multi-drug resistant TB, we have to see whether the resistant to the isoniazid is of 1 gene or 2 gene, and following shorter and longer bedaquiline regimen has to be taken. Next, also an important point noting towards the diagnostic modality, which includes sputum testing, and you have the newer methods like CBNAT, TrueNAT, which is the Indianized version of the CBNAT. Next, you have the line probe assay, which is important in detecting the both rifampicin, isoniazid and other drug resistant TB. Thank you.